Good afternoon. I'm Nick Rebel, the Executive Director of the International College of Surgeons United States Section, or ICS-US. Good afternoon. I'm Nick Rebel. It is my pleasure to welcome you to the latest installment of our Grand Rounds webinar series. We are pleased to partner with NYC Health and Hospitals Harlem in this endeavor. The ICS-US is an ACME accredited provider, and we are delighted to offer AMA Category 1 credit for this episode. Our mission is to unify surgeons and related specialists to promote surgical excellence for the benefit of all people, and our vision is to enhance surgical outreach. Educational activities such as this webinar series are one way that we fulfill our mission and vision. To further enhance our mission, we are seeking new members who are interested in becoming active in our organization, which prides itself on providing a platform for all members to participate at a pace that fits their level of commitment. Visit our website, FICS Online, for more information. It is my pleasure to now introduce our host and moderator of today's program, Dr. Sharik Nazir. Dr. Nazir is a general bariatric and trauma surgeon who became a fellow of ICS in 2015. He is the treasurer of the ICS-US and will be the president of our section in 2025. At the international level, he is currently an ICS World Governor. Dr. Nazir currently holds the position of Director of Bariatric Surgery at NYC Health and Hospitals Harlem and is an assistant clinical professor at Columbia University. And now, our host, Dr. Sharik Nazir.
Good afternoon, ladies and gentlemen. Sorry, there was some technical glitch to starting late, and it's my absolute pleasure to welcome you all to our bi-monthly grand rounds from the Department of Bariatric Surgery at Harlem Hospital. This event is being hosted in collaboration with the International College of Surgeons and our Pediatric Department of Harlem Hospital. And today's talk will focus on the most popular topic, which is a body contouring after weight loss surgery. We have experienced speaker from LA who's going to talk about the latest advancement, technique, and consideration in body contouring procedure for patients who have undergone significant weight loss after gastric bypass, sleeve, duodenal switch, or SADIs. Body contouring after weight loss surgery is a crucial aspect of the overall transformation process for individuals who have lost substantial amount of weight. It involves various surgical procedures aimed at removing excess skin and reshaping the whole body to improve both aesthetic and functionality. Today's event will provide an opportunity for all the attendees to get free CME by registering to the ICS website, and there will be a discussion forum with a panelist comprising of Dr. Ryan Ingerdell, who is the Chief of Plastic Surgery at Harlem Hospital, Dr. Manish Parikh, who is the Head of Pre-Op Services for Health and Hospital Corporation, New York City, and Stephen Carroll, who is currently the CEO of the hospital in Trinidad, and he was the chair of surgery at Harlem Hospital and director of bariatric before. So we are quite excited to have a esteemed celebrity plastic surgeon from LA, Dr. Steven Dominguez, who has really taken his time off from his busy schedule. He works at Milagros Clinic, and he has the privilege of operating in many celebrities, which I can't name them. And he will come with an experience and enlighten us on the latest development in body contouring. So please join me in welcoming Dr. Steven Dominguez.
Hello, everybody. Thank you very much. My name is Steven Dominguez. I appreciate Dr. Nazir's introduction. I will be speaking, as we said today, about body contouring in the post-bariatric surgery patient. So today we're going to be talking about something that's very dear and fond to me, and that is the patient as I just described. Financial disclosures or none. Some basic definitions for our colleagues and friends who are not in the medical field. So the definition of bariatric, you can associate that to mean obesity. Bariatric surgery would be gastrointestinal surgery designed for weight loss purposes. And body contouring plastic surgery is plastic surgery that's designed for the excision of redundant skin, redundant tissue, fat, due to significant weight reduction, and also includes tightening of muscles, typically abdominal wall, for instance. The other definitions we need to have very clear here are excision. So it's the removal of redundant skin and tissue. And this, like Dr. Nazir said, is very important to try to differentiate, especially when we're talking to plastic surgeons or anyone in the field who thinks that plastic surgery is only cosmetic. Well, it's functional, and there's cosmetic excisions. The functional excision is the removal of skin and tissue that's causing secondary medical problems. So if when individuals undergo significant weight loss, they have what's known as pannus, or excess skin and folds. And this can lead to depression. Their body morphology has changed, their vision has changed, their concept of self has changed. It can also exacerbate underlying metabolic issues. And the pannus underneath becomes more moist and creates slight infection, excoriations, or sometimes even frank ulcerations. We're talking about cosmetic excisions, and most of us see that on TV or the celebrity stars. That's removal of excess adipose tissue and or some skin in varying dimensions and places in order to give a better appearance, i.e. liposuction of the chin or brachioplasty of the arms. Those are typically done for cosmeses. So the real question that we have before us today is, are our patients after the surgery for weight reduction, whatever it might be, are these patients seeking cosmetic, I want to look better, or functional, I want to be better, right? So let's see if we can't get to it. Under all this, remember that in plastic surgery, as I've trademarked, beauty is art and science, because that really is plastic surgery, beauty is art and the science. Today, we'll talk more about the science. So functional body contouring, it's the removal of excess fat and redundant skin that follows weight loss. Now, I know today is surgery, but I've had many patients who had significant weight loss through diet, exercise, or through chemistry. But here's the deal. When you lose a lot of weight and you have redundant skin and tissue, 96% of these patients have some sort of a negative psychological effect. Negative enough to either put them in frank depression or start influencing negatively their activities of daily living, how they dress, how they interact with others, and also the health quality of life indicators, we'll talk about soon. So remember, 96%, that's significant for us. And as surgeons, as people in the medical field, we have to understand, why did this change? Remember, they wanted to lose weight to feel, look better, and all of a sudden they're not acting that way. Aha, okay. So the underlying problem that we have with fat is that it's an organ. It's a living organ that has metabolic activity. And because it's metabolic, it secretes various hormones and cytokines that act on the regulation of appetite, inflammation, energy. So individuals will lose weight, they start feeling better, but there still are issues. And those issues, as we can see here from this slide, that it impacts their lipid metabolism, inflammation with C-reactive protein, and sugar levels and insulin through adiponectin. So it's a living functional issue. So when we remove excess fat, whether it's the intra-abdominal fat through diet, weight, and exercise, or through bariatric surgery, or the external, the subcutaneous fat, we still have a very positive biological effect on weight loss, the sustained weight loss. And it also helps to decrease their secondary weight gain that is sometimes seen when you have bariatric surgery. So they lose the weight, and then they plateau, and they start rebounding with weight. Well, we may have some sort of an answer. So again, why is this important? Now, I put this slide in here, and you'll see it's old. It's 2001, because it's still applicable today. And this study with the slide show that when an individual loses 10% of their total body mass, or 30% of the subcutaneous adipose tissue. Significant improvement occurs if you take a look at the right side of the slide, and that's improvement in their diabetes, their hypertension, their renal dysfunction, their inflammation, and this doesn't show up, but the psychological issues. So this is not a novel concept. It's been proven and published at least since 2001 and still applicable today. So if we remove penises, retard abdominal walls, what do we gain? Well, most of the time people are not mobile, and they're not mobile while they're large, and they don't become real mobile when they're not large because of many psychosocial issues, or they just don't have the correct posture. And here's where abdominoplasty may come in and be a positive effect, because we help and stabilize the spinal structures and core muscles through the tightening of the musculature or other muscles. We'll talk about different muscles. The American Society of Plastic Surgeons, and this is a report that was quite astonishing to me when I read it. In 2020, they reported over 47,000 body contouring procedures after massive weight loss. Now, maybe I'm just a little jaded, but that's a lot of people seeking this type of surgery when it's not reimbursed by insurance. So anyways, that's just a fact there. So abdominoplasty, according to the ASPS, says, look, this is the most common procedure that increases a patient's ADL and health quality of life indicators. However, it has a higher complication rate in these patients than any other body contouring procedure. And patients who come in and want breast surgery, face surgery, extremity surgery, etc., complication rate for abdominoplasty is higher. When we're talking about the health-related quality of life indicators, we have noticed significant improvement in reduction of the secondary weight gain post-bariatric surgery. They have increased in their satisfaction and their physical activity, which is really important to me, and an improved continued biological response. We talked about the adipose tissue being a live organ secreting hormones and cytokines. As far as their ADLs, we see after surgery that there's an increase in their mobility and their desire and execution of exercises. They perform better hygiene. Skin irritation infections have decreased. Their psychological barriers or their emotional distresses seem to abate, and their social discomfort improves. This is phenomenal. So when we conclude about the contouring, a meta-analysis was conducted which showed continued weight loss after body contouring with bariatric surgery. So body contouring is not an afterthought. It's part of the whole process that we should consider in our planning on how to address an individual who needs bariatric attention. 85% of people who underwent bariatric surgery and body contouring had improved self-esteem, whereas compared to in the study, 48% of patients who did not have body contouring did not report improved self-esteem. So now we know what we're doing, but there's risks. There's always risks at surgery, right? So what are they and how do we mitigate those risks? Let's go back to some basic terms. Bariatric obesity typically leads to metabolic syndrome. We've known that for 30 years. What is metabolic syndrome for those who don't know medicine? It's a constellation of various factors that influence each other synergistically or together. And that is high blood pressure, hypercholesterolemia, diabetes, chronic and acute inflammations, renal deficiencies. Now you can say, well, I had my procedure, my profile's improved, I'm no longer hypertensive, no longer have significant triglyceridemia, and my blood sugars are great with good H1C. Okay, that's great. However, your risk profile for surgery is still unchanged. Okay. Overlying all this, and we'll talk about this because it's very, very important, is both a macro and micro nutrition deficiency. So we're going to step aside and talk a little about nutrition because I find this to be core to the success of the outcome of my type of surgeries. So I have found that patients who have undergone body contouring consultation in the pre-op have both an acute and a chronic deficiency of vitamins and trace elements. The most significant trace elements I've found is iron, zinc, selenium, and copper. The others are the typical vitamins that you'll find, vitamin C, B12s, etc. These individuals need a lifelong prophylactic dose of supplementation to preserve their optimal outcomes. And that could be due because of their diet. And although see a dietitian, nutritionist in their pre-op, they sometimes revert to their old ways. And their old ways were sometimes attributed to their problems in the first place, not eating the correct foods, not taking supplementation. And, well, they just become malnourished in that response. Or it could be surgically induced after hepatobiliary diversion, fat malabsorption, all the phytochemical vitamins are deficient. What I've also found is that there's some individuals who, although they look healthy, seem healthy, have a good turgor, they have low albumin and total protein stores, again, based on their diet. So here's where I recommend whey protein isolate, and I put them on 40% of their total calories per day as consumption preoperatively, and then I continue that postoperatively. Here's what I give as far as vitamin profile. I recommend the women's daily vitamins with iron. That's for men and women. The B's, the C's, the D's, selenium, zinc, protein, and calcium. So that's what everybody starts taking 2 to 4 weeks before surgery. They continue to take another 2 to 4 weeks after surgery. And we can talk about the cost inherent with that and all that if necessary. So our surgical risks, well, we can divide that into intra-op and post-op at this point. So we know that individuals who are large are difficult to examine and assess. And we're talking about doing a physical examination of the abdomen. There are many hernias that are missed. So certainly one can try to identify readily the umbilical or ventral, but the ones that typically are missed and are present with some frequency are Spigelian hernias. So we can't miss those. Fluid shifts occur, fluid overload, congestive heart failure, PE, blood loss, even cardiac arrest and stroke. Postoperative risks are, again, fluid shifts for up to a week, sugars, high lows, PE, DVTs, poor wound healing, and of course, infection. So in order to mitigate these, in order to address these, we have to have, in my opinion, a anesthesiologist with critical care background training. Why? Patients will have an underlying unknowns or knowns number of medical issues that precipitate intraoperative in a variety of different fashions. And no stones thrown at those who are not critical anesthesiologists, but it's just my comfort level. Remember, these patients are in surgery for 6 hours at least. And the greatest risk is, of course, embolic complications. Plastic surgeon, I'm pretty strong that the plastic surgeon doing this type of surgery has to have a significant amount of experience in removing large amounts of tissue, understand the dynamics intraoperative that could occur in a long duration of surgery, knows how to deal effectively with when encountering adhesions from prior surgeries, especially today when we have hernias and or adhesions from laparoscopic surgery, right? There's unknown blood supply to the tissues that you're either going to anastomose or remove. Where was that blood supply? Where's it going? And are you now devascularizing certain regions? How do you control bleeding? And we'll talk about TXA because that's, at least here in Southern California, becoming a hot ticket of late and with some complications. And again, what do you do when you encounter unknown hernias? So TXA, we're going to talk about this one because I think it's very important. It's tranexamic acid. It inhibits the enzymatic breakdown of existing fibrin blood clots. It's known to aid in the prevention and treatment of hemorrhage in trauma and other certain elective surgeries, ophthalmology, spinal surgery, orthopedics, plastics, burns, etc. It's so effective that the World Health Organization has added to the list of essential medications. But TXA is 10 times more important than alginic acid, EACA. And that's important for you to know if you're used to using other fibrin clot inhibitors. Dosing in trauma, it's 1 gram preoperatively over 10 minutes, and intraoperatively, if necessary, 1 gram over 8-hour period. When we use it on burns and wounds, it's preoperatively 15 milligrams per kilogram. Half-life is 3 hours. Now, what are the risks? Risks are hypotension, especially with rapid infusion. When you couple that with fluid shifts, blood loss, and now you add something that causes hypotension, you need anesthesiologists who can stay on top of things with you. Clotting, DVT, pulmonary embolism. Studies have shown that DVT occurs with 12 times the incidence of placebo, and this has been correlated with dose dependency. Onset of seizures. We're given lidocaine for tumescent fluid. We know that has propensity to induce seizures, and now we're adding another medication. Again, anesthesiology has to be acutely aware of that. Induced renal failure. And of course, the most important is if you use a document extremely well, why the indication, what you used, why you used, and what you expected prior to using it, because it's FDA approved for menorrhagia and hemophilia. So whatever we do as off-label. Okay, post-op. What do we know are the big risks? Well, there was a meta-analysis done by Marco Matuda who showed seroma, wound adhesions, infection, hematoma, blah, blah, all the way down. But pulmonary embolism was known to be mostly fatal. So even though it's low at 0.3% incidence, it's fatal. Okay, so you have to be completely aware in our population that this is a huge risk. All right, pre-op mitigation, you need internal medicine clearance. Whether that includes cardiology, pulmonology, renal, that's up to you and your patient, but you have to have medical clearance. I like to have all the nutritional deficiencies identified and corrected, whether it's dietary and nutritionist or both, or the vitamins, right? I get a CT and MRI of the abdomen. Why? Again, I don't want to miss a hernia that I cannot palpate. So pre-op again, need to be quite clear with the patient and the patient's family that this is not your typical Barbie surgery. This is a large person surgery with a lot of risks, and it has to be staged. So I know that a lot of people will do breast augmentation, breast lift, chin lipo, maybe a lower third facelift, brachioplasty, inner arm lift, along with the abdominoplasty and lipo on a non-bariatric patient. Okay, well, that's more than what I would do, but people do it. Not so with the bariatric patient. It should be staged because of all the reasons that I listed earlier. So a stage approach, make sure patient understands it's not one surgery. And most importantly, the incidence of revisions and touch-ups is high. Why? We're dealing with body that shifts in tissue and size. It heals differently. Your premarcation lines will be shifted, and you're going to have to go back and do a touch-up. And they have to understand and accept this before you engage in the surgery. So intraoperatively, the risk of mitigation, surgeons, anesthesiologists, nursing crew have to have an acute situational awareness of the patient, right? There has to be pre-planning with the whole team, post-planning with the whole team, which includes your lymphatic massage specialist. And we'll talk about why I think that's important. So post-operatively, things go well, things go real well if you engage your massage therapist to do lymphatic massage therapy. In my practice, it's the second most important post-op demand. The first obviously is mobility, get up and walk, right? But there is a large network of lymphatic channels that are damaged through electrocautery, through simple incision. And remember, we don't see the lymph. It just seeps out. And when it seeps out, it accumulates. It accumulates along with all the other transudator fluids, right? And the tumescent fluids, right? And the lysed adipose cells that release triglyceride. It's all a mishmash of stuff that's just sort of there. Well, we need to get it out. We also need to use the current, precise compression garment for that person at that time, right? So not one all binder, not one all girdle fits all always. As a matter of fact, I prefer a loose binder or a loose girdle because compression that is too tight, too high can and will cause tissue ischemia, right? That's preventable, okay? I like when ultrasound and radio frequency is used that stimulates wound healing. Red lights also, right? I begin the process at 40 hours post-operatively, and I bring them 3 times a week to my clinic, not for me, but for the massage lymphatic specialist. So again, lymphatic massage, decreased seromas, decreased hematoma. It increases patient and significant other engagement. Why? They got to get up and come to the office. That's so important, right? And it increases their overall patient satisfaction. And getting up and coming to the office means what? They're mobile. Now, they must be ambulatory prior to discharge. They must be ambulatory at home. And how do you know? Right? Well, you can ask them, and then you're going to find out that they're not. Now, they need to understand our why we feel it's important for them to get up and walk. But we also have to understand their why. Their why is why they're not getting up and walking, why they're bedridden. And I found it's mostly cultural myths, but we need to overcome them. Okay. So in the office, we begin the first post-operative visit. We have a recumbent bicycle as illustrated. Right? You can buy it at Best Buy. I put them on level 1 and have them go 3 minutes. And they're going to be aghast. Family's going to be, they just had surgery yesterday. Correct. But what are we doing? We're breaking their cultural biases, right? Of being bedridden, not being able to walk. They're moving. By the time they get off that 3 minutes, they feel great. They look great. Life is going to be phenomenal. And what? We overcame their anxiety, right? We now have compliance with deep breathing. We now have compliance with get up and walking. And now, and I know it's subjective, but I think I see improved wound healing since I started the mobility addition to my practice. So success, how do we define success? Success is not singular. It's not a patient. It's not a surgeon. It's not a anesthesiologist. It's not a massage. It's a system of individuals who come together to identify and correct medical issues, who have shown surgical expertise, critical care anesthesia expertise, who know how to address the pre and post nutrition needs of patients, who know how to drain the lymphatics, how to apply compression garments and a stage effect. Most of my patients go through 3 girdles in about 6 weeks, okay? And who have mobility, okay? So now we get to the part where everybody's been waiting for pictures. Everybody likes pictures, right? Here's my outcomes, and here's what we did. A 68-year-old female with no metabolic syndrome, under 100-pound weight loss. She has multiple panises, as you can see on the bottom photo, with significant chronic excoriations and ulcers. So she and her husband decided it was time to try to do something for her. She was starting to have some depression, trying to become a hermit. Was a very social individual. Underwent debulking liposuction, abdominoplasty. And here was the decision I had to make. Is this a standard low transverse abdominoplasty incision or a fleur-de-lis? Well, she obviously would qualify for fleur-de-lis, right? A lot of redundant tissue goes circumferential around the back. And here I opted for the standard and, of course, the rectus muscle plication. And you can see the result in the top left. This individual is younger, half the age of the other one. Same metabolic syndromes, same weight loss, multiple panises, no ulcerations, right? But just chronic irritation of the tissue. She underwent standard debulking liposuction, liposculpture, and the abdominoplasty with rectus muscle plication. You'll see I do a lot, or 99% is rectus muscle plication in my patients. There's a young female who had a lap band, 150-pound weight loss, all of a sudden rippling, crimpling of the tissue, redundancy. Life started not looking good for her. So she came in and we did a abdominoplasty with liposuction, liposculpture, and the rectus muscle plication. Now, an individual with a lap band, 60-pound weight loss. That lap band here in Southern California is highly effective. Again, same thing, liposuction, liposculpture, abdominoplasty, and rectus muscle plication. Another individual with 90-pound weight loss, right? Lap band. Again, liposuction, liposculpture, abdominoplasty, and rectus muscle plication. 110-pound weight loss with lap band, same scenario, same result. This individual is a little different. Okay, 47-year-old female professional, 60-pound weight loss with lap band. Okay. So this individual was extremely concerned about her gluteus, her butt. More than her abdomen, more than her flanks. She wanted a good looking butt. So I said, okay, we can do a modified abdominoplasty and not address where the bulk of the fat for your butt will come from, which is the back and the flanks and the hips. And she said, okay. So I did that. 9 months after her modified abdominoplasty, we went and focused on how to improve the look of her gluteus. And you can see the pre and post. Okay. So again, this is an example of a staged procedure, right? We left what she wanted for last because I wanted to make sure that I was going to be able to address her in a manner that was going to be satisfactory for her long-term wise. And some people, as you know, if you do what they want first, they don't come back for what you think they should have done first, right? And that's a matter of negotiation with the patient. So you have two minds coming together, having the best outcome. This young lady, again, with a staged procedure, she lost weight and she had her brachioplasty 8 months after her abdominoplasty. So again, staging in order to get the results you want. This is a young lady, again, with 7-pound weight loss. Now, she lost another 10 pounds in the time between the abdominoplasty and the brachioplasty. So in that period of time, she was on an extremely high protein diet, daily exercise, and she had a trainer. Okay, and the photo at the bottom shows her about 4 months after her brachioplasty. So again, here's where I think that the high protein diet comes into importance, because we're given the dermis the collagen that it needs through protein in order to heal properly and get a better cosmetic result. This lady, again, weight loss, she had already had her abdominoplasty, came back later in stage, and we removed 1,200 cc's of fat from each medial thigh. And notice almost immediately that she is able to close her legs, whereas before she wasn't able to. And this is just a couple of days later. Okay. Breasts, people come in after we're going through diets, and diet can be significant in weight loss. She lost 40 pounds. She used to have nice breasts. Now they're just kind of there. So a transaxillary subfascial approach with silicone did the job. Same here. The transaxillary subfascial approach. That's an approach I like. It's simpler for me. It saves whatever vascularization I may need later if I have to go back and do a formal lift. So here's my conclusion. Plastic surgeons play a vital role in a multi-specialty approach when we focus on the patient and try and improve their quality of life, right? They've already suffered enough from obesity. They've gained success through bariatric surgery, but now they've entered a different field, a different realm, which is not just cut and sew. It's the psychological, it's the social, it's the nutrition, it's encompassing, and that's what we should be doing. So, in conclusion, we do function cosmetic because end result, we want happy patients. Hey, I'm so humbled to be here today. Thank you all very much for allowing me to be here, and thank you again.
Thank you, Steve, for your beautiful talk. With your vast experience, I see in each and every slide your insight and your best practice in body contouring. And thanks for your time. And it's really, truly privileged to have with us here. And now we're going to bring our panelists in our discussion forum, Dr. Steve Carroll, Dr. Ryan, and I think Dr. Manish Parikh is here. So I have a question from we work in New York City, in the East Coast, completely different from the West Coast. And we have been doing tons of patients. And then recently there has been plethora of patients hanging out outside and really want to talk about the plastic surgery. And as you know that we have three groups of patients in our hospitals. We have the patients with the commercial pay, which has good insurance. Then we have a patient with the self-pay. And then we have a patient with a Medicaid. So now the question comes in about the insurance. So how do you play around? How do you circumvent the system and get the patients who cannot afford the operation and really needs the surgery to be done? So how you make sure it happens there?
Are you asking me?
Yes, Steve.
Oh, okay. Yeah, sure. No problem. So my patient population is just as you described. Unfortunately, here in Southern California, the traditional insurances, third-party PPOs, will not pay for the work that I do encompassed. So they require a patient to have significant ulcerations treated by their primary care physician, 4 instances in a 12-month period, in order to qualify for paniculectomy, right? And we all know what that is, and it's not what you saw, right? If that's what they need and that's what they're for, that's what we do. I'm not in favor of combining cash and insurance procedures at the same time. I think that's just fraught with risk for the surgeon. So if it's a paniculectomy that's paid for, we'll do it, but that doesn't encompass everything. For the patients who are on Medi-Cal here or Title 19, it's good luck. It's not going to happen. Right? Basically on conservative treatment by the primary care physician. Medicare won't pay for it either. So the cash pay patient, it's out of pocket. It's significant. That's why most people want to have everything done at once, right? Because they know repeated trips to the operating room cost money. But here's where sitting down and speaking frankly with your patient and the family on what is it we're trying to achieve here, and how do we achieve this safely? And I'll tell you, my limit is 6 hours. If I can do surgery in 6 hours, I'm done. If it's 8, 9 hours, it's staged, right? 2 to 3 sessions, along with infection. I'm not going to put a patient through a breast augmentation, doing the transaxial approach, or doing a lift or some other surgery, especially a thigh lift, at the same time because the risk of infection is so high. It's just not worth it to them. It's not worth it to me. So we're staging it. And I'll be honest with you, if my patients say, it's not what I want, then you know what? Let's go see, Dr. Merrick Dopke at UCSD and see what he advises. Punt to the university, right? Let someone else, say, yes, this risk is worth taking. Here's what we can do to mitigate that risk. Or again, say, no, we got to do a stage approach. So I'm not the end all. I'm just a provider of information and consultation. But again, the first thing is patient safety.
Thank you very much. So we have Dr. Parikh. He's our head of the pre-op service for New York City Health and Hospital. What do you experience, Dr. Parikh? Because I came from different institution and we have completely different way we used to push forward the patient for surgery, and that really used to happen. But what do you take message for us in working at the city hospital? How you go along with the patients who cannot afford the plastic surgery and they really deserve it, really need it?
I think I'd go by what Dr. Dominguez was saying, which is start with what we can get approved. I agree that the paniculectomy alone is not going to completely satisfy their body contouring needs, but if we can get that approved, that's at least part of the way there. And I think that they're still going to benefit from it from a functional standpoint, and we can deal with the other things later. But I think we have to work within the confines of insurance and what insurance will approve, and kind of like with bariatric surgery, where different insurance companies have different criteria, who will cover what, and we have to kind of tailor the pre-op program based on the insurance. We have to do the same with this based on the insurance.
In the previous hospital, we used to write the documentation, like, for example, with the large pannus, with the dermatitis, the back pain, and all these different symptoms. And then in the plastic surgery team there at our hospital, previous hospital, used to work with the insurance and get things approved. So I'll ask a question with our plastic chief at Harlem Hospital, Ryan. What is your thoughts about how you go along with this group of patients?
I'd like to thank you for inviting me in here at Health and Hospitals. I agree with what everyone said in the panel. We have a little probably more leniency than maybe California in terms of some of the insurance plans. I think it's very important that the patient brings in information, and whether it's from another provider or the referral, and that we have a frank discussion, as Dr. Dominguez says, on what are we trying to do, what are the goals, what can a functional surgery do and benefit versus some other things. And then I think there's a variety of insurance plans. There's not just one. And you sort of have to look at some of the criteria the insurance plan would be combined with the patient's examination and the information that we have, and obviously your office visit. And after that discussion, we can go ahead and try for and select patients insurance-based procedures for more functional things, knowing, as Dr. Dominguez fully pointed out, it's not a cosmetic surgery. It's more focuses on functional with a cosmetic benefit in many cases.
Yeah, we have Dr. Carroll. He's a CEO at Trinidad Hospital, and he was the former chair at Wyckoff. And apparently has some experience in doing himself, being a bariatric surgeon. He has taken care of a lot of patients doing paniculectomy, abdominoplasty, and other stuff. Dr. Carroll, you want to have some share your experience?
Yes, I appreciate the opportunity of speaking here, and thank you, Dr. Dominguez, for your very expert overview of a difficult subject. My experience grew out of running a support group for 15 years, and I'm not sure about every jurisdiction, but in Brooklyn, the common thing was that most of the plastic surgeons would not accept insurance. That was just the common practice. So at Wyckoff, we actually created a path only for post-bariatric patients that allowed us to work with the plastic surgeon. I myself had to go to what is called extension of privileges with training in Brazil, mentorship. And so we were able to do the surgeries for patients, even almost agnostic of their payment method. The hospital was willing to take whatever Medicaid or whoever paid. I don't think it's an ideal path, but I wanted to know what is Dr. Dominguez's thoughts of working along with, in extending your privileges or in some way developing the expertise in this area.
I think that developing the expertise is a matter of time and effort put in by the surgeon with the desire and the surgeons and institutions willing to teach, right? Like you said, going out of the country, right? Or finding a mentor. Finding a mentor is extremely important at every stage of our professional careers. And I think that that's how we learn. And we say, we're at a certain stage in our lives where we're going to focus remaining career years on a certain phenomenon. In this case, it's the body contour and post-bariatric. It fulfills, at least in my regard, a intrinsic need to give back. When you see the turnaround of the patient's personality, the reversal of depression, their social outlook, their mobility, it's truly functional. And everybody can debate whether it's just cosmetic or not. But I think the research is there done by people in public health, social studies, and in medicine that are actually proven what we feel with our functional surgery. But it's not something that I think is routinely taught. I think it's something, like you said, it's not paid for by insurances. It's done cash out of pocket. That's why I was surprised by the SPS figure of 47,000 patients. To me, that's too high, right? I'm not sure how they got to that, but I don't see that as that prevalent people with that type of cash flow wanting the surgery. So I think if you're going to start. Identify your mentor, identify your institutions, and go learn. It's going to cost you time, money, and effort, and then work to trying to serve a need in your community. I don't think that there is a program specifically designed for this. I wish there was. Maybe I'm wrong. There is. But nonetheless, seek it out and do it. But do it with your heart, not with the eyes green on the globe because you're going to make money, because there's really not a lot. It's a lot of work. There's more work, I'll tell you, in my pre and post-op with this patient population than with any other population I've encountered in 40 years of practice. Right.
I appreciate it. Thank you. Very good answer.
Thank you, sir.
You're welcome.
What does it take, Dr. Bariatric, about us being a bariatric surgeon taking care of our own patients? I know it's not easy because we have our own dedicated plastic surgeon in our hospital with the 4 plastic surgeons. The chief, Dr. Ryan, is here. I have done a couple of cases myself, and I've seen people at they doing this abdominoplasty in the private office, and they called me when I was a fellow, and they paid me, to assist privately, and they have done it, and they've been doing it.
I mean, we've taken courses as well and learned how to do it. Kind of like what Dr. Carroll was saying, but I think ideally we invest the time and effort, as Dr. Dominguez is saying, to get the kind of right personnel to do it, who have an interest, an academic interest, a clinical interest, to take care of these patients. I think it is a challenge in this particular setting, in the public health setting, but it's still feasible. We've seen it with Dr. Engdahl. I think it does come down to really understanding the differences with insurance companies here in New York, and tailoring the documentation accordingly, and making sure the patient's on the right path preoperatively based on what the insurance companies require.
Yeah, very true.
We have, I think, 5 more minutes. If you have any questions, any discussion forum, we can ask Dr. Dominguez, and we can share. We have tons of questions coming up online. Actually, they're asking about the first question is this type of surgery covered by insurance? We discussed it. And they're also asking, are the patient hospitalized if they go under for paniculectomy, and for how long? They have to stay in the hospital.
Okay. So in my practice, this is 100% outpatient surgery. So I utilize surgery centers where the critical care anesthesiologist and my team can work. If a patient, however, comes in with several comorbidities, well, that's going to be beyond the scope of what I want to entertain with. So like I said, I refer them to the university where the team is there, right? And, I'm fortunate that UCSD, Dr. Dobke, is down there to receive them, and he's an expert in this field also. So they are well cared for. Their pre-op, their surgical procedures, their post-op care is all at the hospital at the university. And I think that, again, significant comorbidities require that type of an environment. And again, number one is patient safety.
Thank you. And another question is, can patients on blood thinners have this surgery, like they're on Plavix and aspirin, or other medications on board?
That's a really good question. I'm sorry.
Yeah, and the other blood thinners,
That's a very good question. For a simple procedure, the answer is yes. If you are in complete coordination with typically it's a cardiologist, right? And you're able to take them off and put them on, and for a very short period of time. I try to limit those surgeries to like 3 hours, not the 6-hour surgery, right? And again, it's telephone talks with the cardiologist to make sure they're fine. If it's something that's more critical, then again, straight to the university.
And do you have any age limit for performing the surgery?
I personally do not have an age limit. I've had surgery on patients that are 80 years of age who are in perfect health. They underwent their weight loss procedure. Now, a lot of people go from Los Angeles to Tijuana, Mexico, and they have all surgical bariatric procedures, and they come back losing, 6 months later, 60 pounds. And they don't have the pre-op, they don't have the nutrition, they don't have the psychology. They just had a procedure done in Mexico, right? So that's where the effort goes into the pre-op and the post-op for me. But as far as age, like I said, I've had individuals who have no cardiac disease. They see a cardiologist, they get a stress test. They don't have, significant hyperglycemia. They've got the cognitive wits about them. I've also had patients who are in their early 60s who I won't operate on because not of age, but of course because of their comorbidities. So I don't think age is the final end-all determinator of whether one can undergo.
I will ask the bariatric surgeon, Dr. Parikh, what is the maximum age you have done the obesity operation on?
Probably 78.
Oh, really? Okay. How about Dr. Carroll?
How about 74?
74. And what is the maximum BMIs you have done it?
105, I think.
Oh.
Now, I hit the 100s.
Wow.
Dr. Hindal, you have some question you had?
Yeah, just a comment on the whether you go home or stay in a hospital. I think it depends a little bit, like Dr. Dominguez says, what your, how much tissue we're removing, what your comorbidities are. And a lot of patients in the city health system will stay overnight for observation. Obviously, if they're having a greater amount of tissue removed or other issues, it could be longer. Or there's an option to go home with a close follow-up.
Okay. Yeah, please.
I'd like to follow up on that. You're right, doctor. Some of my patients who don't have significant others to take them home or stay with them, I mandate that we get a nurse to spend the night, if not 2 or 3 nights. And either my staff will go, make sure they're okay during the day, or we'll get another nurse. So that's an added cost. Not have someone or people at home to take care of them in the immediate post-op period.
Okay. Just a quick 2 questions. Let me cover up. What will be the recovery time for the patients who are going for this type of operation? How long they have to stay in the hospital, and when they go back to the work?
Yeah, so I don't hospitalize them. So they go home. And they're up and about that same day in the surgery center. We make sure they're up and about POD1 because they come see me, and that's when I put them on the bicycle. And that's where they learn they can take deep breaths, they can walk, they can ride a bicycle, and it changes their life. Without it, I'll tell you, people were bedridden, myths, right? Oh, I had surgery, I can't get out of bed for, a week. I just bring me a pee pad. No, right? Get up, right? And that, I think, is the biggest thing that we can do. As far as them going back to work, 2 weeks typically, right? With the caveats of no lifting, no pushing, no pulling, everything greater than 5 pounds or 3/4 of a jug of milk. Drains typically come out at about day 4 to 10, right? Rarely day 2, sometimes day 14, right? And each drain is separate. Less than 20 cc's per 24-hour period, documented. Pull out the drains, right? Suture removals, 10 to 14 days, right? Once they're out, 2 days later, they can shower. Just don't jump in the pool or take a bath. They're ambulating, depends on their work. If they're sedentary at a desk, go to work, right? If they're, a machinist, well, no, they're not going to be able to go to work. So it's all dependent. But typically, that's the scenario I present to my patient.
Okay. So since we have audience from all across the country and across the world, there's another question come up here. Can this surgery be combined with other surgeries such as breast reduction or bladder lift?
Yeah, the answer is yes, but the answer is no, right? So I take a look at what am I trying to achieve in the safest manner. So safety includes length on the table, risk of DVTs, both intra-op and post, risk of pneumonia, risk of other infections. So we're talking about breast augmentation or a lift, that can be delayed. I can do that months later. As far as a bladder lift, that's an infectious area, no different than a thigh lift. And I'd say, no, I'm not going to do the same time. And yeah, I've heard the argument. I'm there. The gynecologist, general surgeon come in. They can do the procedure. And then they'll tell me, I'm in, I'm out. Yeah, but you're in, you're out of my field, right? And I want to keep my field as sterile as I possibly can without inducing comorbidities. For me, that risk is not worth my patient having some issue or issues that were preventable, and that would be preventable. So my answer is no.
Okay. And this question goes to both plastic surgeons from East Coast and West Coast. What should be the minimum time gap between the body contouring and bariatric surgery? Yeah.
Well, when the bariatric team, right, excluding the plastic surgery, says that they're ready, right? To me, I like it when they've gone through the system here, of psychiatry, dietary, nutrition, exercise trainers, medical clearance, all that, right? And that whole process sometimes up to a year if you go the traditional route. The bariatric surgery itself starts having gains fairly significantly, and they lose. Those to me are weight loss gains, and they sort of plateau, right? At some time in that plateau, when the team says, okay, you're healthy, you're well, you can go have your bariatric body contouring surgery, then that's what I'd like to enter the picture. Unfortunately, here in Southern California, I don't have that because people go out of the country, so they miss all that, right? So typically they'll come into the practice at about month 5 to 7, because that's when they've seen the plateau. That's when the paniculosis and the body dysmorphia starts to kick in, and they want some attention. But ideally, it would be in coordination with the team.
How about Ryan? What is your practice
Yeah,
here?
I think that the two main things I think about are what's maximal weight loss or close to it, and what's the best nutrition. And that's typically around 18 months to 2 years out. There are some case-by-case basis where there's overwhelming problems with excess skin or other factors, or a patient that might be early in that process that I'll go before that. It's fine that you refer to the plastic surgeon, earlier to be on board and get a plan, but generally about 18 months to 2 years we're looking at for most patients, unless there's some other factors. Again, some of this can be case-by-case basis, and I agree with Dr. Dominguez. You want to follow with the plastic surgeon and make sure that their team is fully aware, and the patient has all their other factors such as nutritional deficiencies the best they can be.
Another question came from residents here. Is there any absolute contraindication to body contouring for post-bariatric surgery patients? Steve and Ryan both can jump in.
Absolute. I would probably say cardiac. Right? If someone has had significant cardiomyopathy, and I don't think they're going to sustain a 6-hour surgery, then there's no way I'm going to take them to the theater, right? So that would be my big one. The other one is when I interview the patient, if I find that the patient is being less than honest, doesn't seem to grasp the significance of the surgery, the postoperative care, because it's pretty detailed. I mean, they got to come to the office quite a bit. Then I'm going to elect not to engage with them.
Yep. So I think we'll wrap it. Thank you very much, Dr. Dominguez, for using wonderful time from the West Coast, and the panelists for sharing your expert experience and informations. And this webinar has really inspired me and the audience with the depth of knowledge which has been shared, and is going to really last impact in our clinical practice. And for this, thank you very much, and for your time, and looking forward for the next webinar. Thank you. God bless you all. Bye-bye.
Thank you very much. Thank you.
You're welcome.
Thank you.